So, Monica, what do you mean by partial response in lupus nephritis? And how do you mean by rapidly progressive glomerulonephritis?
Yes, sir. Partial renal response, we say that partial renal response is attained when there is at least reduction of at least 50% in UPCR, that is urine protein creatinine ratio, and normalization or near normal GFR if the baseline GFR was reduced. Then this target should be preferably achieved by 6 months and no later than 12 months after the treatment is initiated. To complete the discussion, the complete renal response means UPCR reduction below 0.5 to 0.7 gram per day and normalization of the GFR by 12 to 24 months, which is the ultimate treatment goal. And to define RPGN, it is a clinico-pathological syndrome with rapid loss of renal function over very short period of time, that is days to weeks, and having nephritic urine analysis picture, that is proteinuria, hematuria, dysmorphic RBCs or RBC cast and histopathological findings in renal biopsy shows cellular crescent formation in the glomeruli, which is nothing but proliferative cell response in the Bowman's capsule.
So, my next question to Dr. Sarbani, Dr. Sarbani Sengupta, I think Madam has joined. Madam is trying to join actually. So, may I go to the next question? You can ask Madam the question when Madam joins. Monica?
Yes, sir. I think we can come back to this.
We can come back to this question later. So, Monica, go to the next.
Okay.
The next question is to Pradip. So,
yeah.
Dr. Pradip, do you think that we manage the patient adequately, or there was any deviation in the management?
Yeah. Can I go to the next slide, please? Yeah. So, good evening, everyone. So, C has actually multiple components involved. One is I want to just highlight anemia in SLE can be multifactorial, and they have evaluated direct Coombs is negative. C has iron deficiency. She may have anemia of chronic disease. But I also want to do one peripheral blood smear because she has thrombocytopenia, she has renal failure. So is she having microangiopathy also? So that's why in this patient, peripheral blood smear is also very important to look for cystocytes. Then she had a mild degree of thrombocytopenia. I also want to know what is the level of thrombocytopenia? Does that actually, whether we can go for renal biopsy or not? I'll come to that, whether to go for renal biopsy or not. Then, regarding labeling her as RPGN, so what is the duration of the disease? That is also important because we are seeing in the slides that she has increased creatinine from the beginning. So whether it is acute kidney injury or what is the duration? Is it a chronic disease? So I want to know also that one. And regarding that microangiopathy, renal failure, along with that, antiphospholipid in the antibodies also become very important because in the kidneys he may have thrombosis also. So regarding the next slide, please.
Sir, I just wanted to answer that in this patient, actually, there was no acute drop in hemoglobin and DCT was also negative. We had done the peripheral smear, but there was no evidence of any schistocytes or hemolytic picture. And the RPG and duration, over a period of just 2 weeks, her creatinine had increased from 1 to 1.6. And also her APS profile was negative. All three antibodies were.
Yeah. So next slide, please. So, and at what time point we should do a renal biopsy in a patient of SLE? So standard is we should do at the initial presentation. What are the indications? We'll come to that one. Then when the patient require repeat biopsy, some patients may require repeat biopsy. Repeat biopsy when patient does not respond to that treatment. Then if the patient has a relapse or say after a few years, if you want to withdraw all immunosuppressants. So these are the time points where a patient needs a renal biopsy. Next slide, please. So there is pros and cons of doing a renal biopsy at the faster indications. So pros are, it is a standard care for diagnosis of lupus nephritis. That is the gold standards. And some patients with renal disease, though rare, but still that is a possibility. 5% of SLE patients have actually non-lupus glomerulonephritis, like common is IgA nephropathy, then FSGS. So these are the other kidney disease where patients, SLE patients can have. Then thrombotic microangiopathy is another important differential in a patient of lupus who has renal involvement. Then detection of degree of inflammation, what is the activity, what is the chronicity. Then,
Hello, Dr. Sarbani.
yeah.
Am I visible?
Then, and we also should remember that there is a considerable discordance between clinical features and histological disease. But what are the cons? In a patient with new SLE diagnosing requiring immunosuppression with classic lupus nephritis, like this patient has, there is a low probability for Parashar, some background is coming from my side or from other side?
From other side.
It's audible, but am I?
Dr. Shravani madam.
Yeah. Okay.
Plus,
So what are the cons of doing a biopsy in a patient like this patient? She has nephritis. She will definitely require immunosuppression. So what is the point? Then at present, mostly we don't go for the standard of treatment is either we use glucocorticoid along with mycophenolate or cyclophosphamide. So most of the nephritis we treat that way. Then and that prognosis, whether biopsy actually we can do go for prognosticate that patient or not with biopsy. That is still some studies so say okay there is prognostic value, there is chronic changes, but still there is a long way to go whether biopsy can predict long-term prognosis or not. And still we do only histology. We don't go for electron microscopy in our patients, most of our centers. And so these are the cons for doing a biopsy. Then when we do, what are the indications in a lupus patient? All SLE patients does not need a kidney biopsy. So what are the indications? Actually, we have ACR guidelines, we have EULAR guidelines, and recent this is the KDIGO guideline, kidney disease improving global outcome. So this is the most recent guideline. But all guidelines actually varies in a subtle way. But if we look at throughout the years, when we do a renal biopsy, say if proteinuria is 1 gram, that is indication. If the patient has renal failure, that is an indication. Proteinuria 500 along with low C3, high dsDNA, then that is an also indication for renal biopsy. Proteinuria 500 milligram along with active urine sediment, those are the indications for we should consider doing a renal biopsy in a patient of SLE. Next slide, please. So she still has she has received probably 4 doses of cyclophosphamide till now. So still she has not responded. Probably she will need a biopsy, but the issue is whether we'll do biopsy now or we can wait for another 2 months to complete the protocol, NIH protocol. Then we should probably go for a renal biopsy if she does not respond. She is partial response, so we can wait. There is no rush in doing a renal biopsy at this point of time. Next slide, please. So, and how we treat SLE patients, it is not only, we should focus only on the kidneys only. So we should approach holistically. So most of our SLE patients, we know that die of, because of initially they die of infection and later on they die of cardiovascular disease. So assessing the cardiovascular risk factors is very important. So lifestyle modification like smoking cessation, body weight optimization, regular exercise, those are important. Then lipid profile, we should check. Then low dose aspirin during pregnancy, then controlling blood pressure is very, very important. And she had resistant hypertension. Then proteinuria and CKD progression. Then we should avoid, we should ask them to avoid high sodium diet. Then we should optimize their blood pressure. Then if she is hypertensive, so we should provide her renoprotective medications like RAS blockade or SGLT2 inhibitor. Then avoid necrotoxic insult is very, very important. Then these patients are at risk of infection. She had multiple episodes of infection. So assessing the infection risk is very, very important. And we can think about vaccinating, but again, cost become an issue in our country. Vaccinations like influenza and pneumococcal, and even nowadays herpes zoster vaccination is possible. Then we have to look at the bone health. Supplementation of calcium and vitamin D is very, very important. Regular exercise also is helpful. Then protection from ultraviolet light exposure. Then this premature ovarian failure is an issue because most of our ST patients receive cyclophosphamide. Then we should counsel about pregnancy. Then we should always evaluate for risks for cancers. Next slide, please. And regarding the steroid, she has received methylprednisolone plus 250 milligram for 4 days, followed by prednisolone 0.5 milligram per kg. So this is an adequate dosage because nowadays the whole world is moving using lesser and lesser steroids to treat SLE patients. But methylprednisolone plus was importantly. So how much dose we should use? So people use from like this previous slide, please. Previous slide. So like you are using 250 milligrams, so we can use from 250 to 1 gram. How much we use that actually from center to center. And importantly, so one is steroid is associated with many side effects. Importantly, methylprednisolone, whether those side effects are with that methylprednisolone pulse is there or not, we are not sure. One study has shown that like some side effects, like avascular necrosis, that is not associated with methylprednisolone. So how much prednisolone we will use that differ from center to center, but sick patients like that, probably we can go higher dose like 500 milligram or so. 1000 milligram most of the time nowadays.